Welcome to the deep dive.
Welcome to the deep dive.
Okay, so let's float right into it. We are diving into a really monumental shift in global public health. I mean, this is something that affects, well, potentially every single person listening, either directly or, indirectly.
Absolutely.
We're talking about the World Health Organization's brand new 2025 guideline on using GLP-1 therapies. You probably know them as slimming shots.
That's right. And, while the drugs themselves get all the headlines, the biggest takeaway from this, it's not actually the drug. It's the conceptual earthquake happening underneath it all.
An earthquake? What do you mean by that?
The WHO has officially made a definitive declaration. They're saying obesity is a chronic and relapsing disease.
A disease.
A disease, one that requires long-term, maybe even lifelong care. It's a complete rejection of that old simplistic idea that it's just about willpower.
Wow. So this isn't just about a new pill or a new shot. It's a new definition on the world stage. That changes everything. I mean, for health systems, insurance companies, even just for us as individuals, it puts obesity in the same category as something like hypertension.
Right. Something you manage continuously. This is a major, major tipping point. And for anyone who's ever struggled with their weight, it's a validation that the struggle is rooted in complex biology, not some kind of moral failure.
Okay, so let's start with the why. Why this radical change now? For decades, it's just been eat less, move more.
Well, that view isn't just incomplete. It's actually pretty misleading. The source material is really clear on this. While diet and exercise are factors, of course, obesity is driven by this whole complex web of interactions. Many of them are way beyond an individual's control.
Like what?
We're talking about genetics, neurobiology, so how your actual brain chemistry regulates appetite, and then specific eating behaviors that are tied to that biology.
So it's not just counting calories, it's a brain chemistry game.
Precisely. But the other critical piece the WHO highlights is the external environment. They call them obesogenic environments.
Obesogenic, meaning designed to make us obese.
In a way, yes. Think about it. Because of globalization and industrialization, we live in these environments that are just, they're engineered to make us gain weight.
Cheap, ultra-processed food everywhere.
Exactly. Calorie-dense foods are everywhere, and most of our jobs are sedentary now. The deck is just stacked against our biology.
So we're not just fighting a personal battle with the snack cabinet, we're fighting a systemic problem.
That's the core of it.
And that really puts the scale of this crisis into a terrifying perspective. Just how bad is it globally?
The scale is astronomical, truly. We're talking about over 1 billion people affected by obesity worldwide.
A billion.
A billion people. And the scary part is the cases are rising in almost every single country, rich or poor.
That is just staggering. And of course, the consequences aren't just about how you look. They are literally deadly.
They are. I mean, the mortality data is impossible to ignore. In 2024 alone, there were an estimated 3.7 million deaths related to obesity. That's 12% of all deaths from non-communicable diseases. It's a massive strain.
And what about the economic cost? I mean, 1 billion people with a chronic disease. That has to be catastrophic for the global economy.
Catastrophic is the right word. The global economic burden is projected to hit an eye-watering $3 trillion per year by 2030.
Trillion with a T.
Trillions. And that's not just healthcare costs. It's lost productivity, disability, all the indirect costs. It's a massive anchor on the global economy.
Okay, so it's clear we needed a major new tool, and now we have one with GLP-1s. Where did these drugs even come from?
It's actually a classic scientific story. They were first approved way back in 2005, but not for weight loss.
Right, for type 2 diabetes.
Exactly. Their job was to enhance insulin, suppress glucagon, basically just normalize blood sugar.
But then patients started losing weight, and I imagine that was the big aha moment.
That was it. The realization was that these drugs weren't just working on the pancreas. They were having this profound effect on the central nervous system.
On the brain.
Specifically, on the hypothalamic pathways in the brain that regulate hunger signals.
That is fascinating. So how does that work? How does it actually create such effective weight loss?
Well, the mechanism is really a three-pronged attack. First, it acts on the brain to reduce hunger signals.
Yeah.
You just don't think about food as much.
Okay.
Second, it enhances satiety, so you feel full much faster. And third, it actually delays gastric emptying, so the food stays in your stomach longer.
So you're less hungry, you feel full faster, and you stay full longer.
It's a biological trifecta. It basically recalibrates your body's relationship with food.
I can imagine that frees up so much mental energy for a patient. It must make those behavioral changes so much easier to stick with.
That's a huge part of it. But what really convinced the WHO wasn't just the weight loss, it was the whole spectrum of other metabolic benefits.
Right, the unexpected benefits. What else is this powerhouse drug doing?
It's kind of transforming how we treat cardiovascular disease. We're seeing it can help prevent major cardiovascular events like heart attacks and strokes.
That's huge.
And it can also treat really complex issues, like a specific type of heart failure that's notoriously difficult to manage.
So it's not just helping with weight, it's protecting our most vital organ.
And it doesn't stop there. We're seeing improvements in obstructive sleep apnea, in chronic kidney disease, even in fatty liver disease.
Wow.
The sources even hint there might be links to reducing inflammation that could affect neurodegenerative diseases down the line.
So it sounds like we're just at the very beginning of understanding what these can do.
We really are. Right now, there are 12 approved GLP-1s, but there are over 40 more in development. This is clearly the path forward.
So with all these incredible benefits, you'd think the WHO would just issue this massive unconditional mandate to use them everywhere.
You would think so.
But the recommendations are conditional. What does that actually mean?
That word conditional is absolutely vital. It basically means the WHO supports the therapy in principle, they know it works, but they also recognize these severe real-world constraints.
Let's break down the recommendations first. What is the WHO actually telling countries to do?
Okay, so recommendation 1 says GLP-1s may be used as long-term treatment for adults with obesity, and long-term is the key phrase there.
It's not a quick fix.
Not at all. It reinforces the idea that this is a chronic disease. If you stop the medication, you'll likely relapse, just like with blood pressure meds.
Got it. And what's the second part of the combo?
Recommendation 2 is that the medication must always be paired with intensive behavioral therapy, or IBT.
So it's not just about the drug.
Right. It's a comprehensive approach. And IBT isn't just vague advice. It's structured goal setting for diet and exercise, calorie restriction, and ideally, weekly counseling.
So the drug handles the biology and the therapy handles the habits and the environment.
Precisely. The combination is what amplifies and sustains the benefits. You need the pharmacological break, but you also need the behavioral steering wheel.
Okay, now back to conditional. If the drug is so good, why hold back with the conditional recommendation? What are the big roadblocks?
The roadblocks are almost entirely systemic and economic. First, we have limited long-term safety data, just because they're relatively new for this purpose.
Okay, that makes sense.
Second, and this is the big one, the high current cost is just. It's prohibitive for most countries. And third, most health systems just aren't prepared for this kind of demand.
And what's the fourth constraint?
So the fourth is the potential for huge equity problems. I mean, if only wealthy people or wealthy countries can afford this, we risk making the global health gap even wider.
So the WHO is essentially saying, this works, but we can't tell everyone to use it until we solve the massive access and fairness problem.
That's it exactly. Yeah. We have a scientific solution to a trillion-dollar problem, but it's a solution that's currently only available to a tiny fraction of the people who need it. And it absolutely is. The source material calls this a profound equity dilemma. We know how to treat 1 billion people, but we can't actually reach them.
Let's talk about the supply problem. Just how big is that gap between who needs it and what we can make?
The numbers are pretty stark. Even with the most optimistic projections, current global manufacturing capacity could only cover around 100 million people.
Wait, 100 million, but you just said there are over 1 billion people affected.
Right.
So we have capacity for less than 10%. That is a radical supply constraint.
It is, and it means every health system in the world is facing these impossible choices about who gets priority.
So what is the WHO actually doing to try and fix this?
They're focused on system-level changes to drive down cost and increase supply. Things like WHO pre-qualification, which helps ensure quality. They're also pushing for pooled procurement, tiered pricing, and enabling widespread generic production.
Generic production sounds like the real game changer. Is there a key date we should be watching for?
There is. The expiration of the patent for semaglutide, that's one of the main ones, in 2026.
2026.
That's expected to be a crucial moment. It opens the door for generic manufacturing, which should, in theory, lead to the massive price reduction we need for real global access.
But until that happens, we still have to prioritize. So who gets it first?
That's their next urgent task. The WHO is meeting in early 2026 to define a clear, evidence-based framework for prioritizing treatment.
Now, what will that look like?
It will likely be based on disease severity and comorbidities. So people with obesity who also have type 2 diabetes or major cardiovascular risk, they'll probably be first in line.
So to bring this all together for you, the listener, the big news here isn't just the drug, it's the global paradigm shift. Obesity is a complex, chronic disease.
That is the essential message. The availability of these drugs, it has to be a catalyst. We have to build a fair, integrated, and sustainable obesity ecosystem. The medication alone can't solve this.
Right. It means we need to train millions of healthcare workers for the behavioral therapy side. We need to integrate this into primary care.
Absolutely. And we need to shift resources away from just treating the consequences of obesity, the heart attacks, the strokes, to proactively managing the disease itself. It requires huge system-level interventions.
From reforming food production all the way down to who gets a prescription.
Yes.
It's an incredible moment where the science has given us an answer, and now the policy has to catch up. So, for our final provocative thought for you to mull over, if medication alone can't solve this, and the goal is health equity for over 1 billion people, are we as a global society actually prepared to make the huge systemic investments needed to make sure this breakthrough benefits everyone? Are we ready to transform our food systems, our cities, our insurance coverage, or will this moment just become a massive, tragic, missed opportunity for global health?
The way the world answers that question, that's going to write the public health history for the next 20 years.
And that's a wrap on this episode of MedDecode. I really appreciate you joining me today. If something we talked about sparked your interest, or if there's a medical term that's been bugging you, let me know in the comments. And if you enjoyed this, be a pal and share it with a friend. We'll catch you on the next one.